Okay, we are going to take our seats so we can get started. Hello. So I want to welcome everyone to Neurology Grand Round's first CPC for this academic year. And today, and also we're going to welcome our resident applicants. Thanks for coming. Today we have a treat. Mike Freeburg and Makeda are going to be presenting a CPC today. There are two of our outstanding neurology residents, and our faculty discussant is going to be Dr. Michael Weiss, who is an expert in neuromuscular disorders. I'll just give a one-liner on Michael. He's Brown University graduate, and then to Albert Einstein College of Medicine. He did his neurology residency at Georgetown, correct me if I have any of this wrong, and a neuromuscular fellowship at the University of Maryland, and another second fellowship at NIH, NINDS in Bethesda. And he's been on faculty here a number of years. He's a fantastic resource for all our neuromuscular patients, and we're glad to have him. So with that, I will turn this over to Nick.
Thank you, Dr. Weinstein. We are very fortunate to benefit from Dr. Weiss's expertise today in our CPC. First of all, I wanted to give a warm welcome to the neurology applicants who are here for the residency program. And just to start off with a little plug, this is a common view from Capitol Hill, where you could easily live as a resident. All right. So we will begin with the one-liner on this case. The patient who we saw at the VA was a 68-year-old gentleman transferred to us from Boise for 6 months of severe progressive weakness, sensory loss, and gait instability. So that is the very brief overview, and we're going to start just by having Dr. Weiss give us a differential diagnosis, casting a wide net based on that alone, and then we'll narrow from there.
5 minutes on each topic, Michael.
No, I'm not going to dwell because it's. I've been asked to help with the CPC. I just assume there's a neuromuscular question here, so I'm not going to talk about some of these disorders in any detail. But clearly, the differential diagnosis is quite broad for somebody with that presentation, and so this could be a disorder of the central nervous system. It could be a disorder of the brain. The patient could have a brain tumor. Could have had multiple small strokes, could have vasculitis of the central nervous system or some inflammatory process like MS, spinal cord disorders. There's no mention about where the weakness is, but it could be compressive myelopathy. The patient could have a dural AV fistula with ischemia of the cord, could have involvement of the anterior spinal artery, although I would think that would be maybe more acute. Syrinx that's emerging, inflammatory causes, there are a number of them, including spinal presentations for MS. And then another category of disease would be the myeloneuropathies and concomitant involvement with spinal cord and peripheral nerve, and most notably that would be B12 deficiency, which can present subacutely, and then other vitamin deficiencies, including copper deficiency. I've certainly seen my share of those patients. Paraneoplastic causes, inflammatory causes such as lupus or rheumatoid arthritis, presenting with myelopathy and peripheral neuropathy, and then infectious causes like HTLV1 and 2, although I wouldn't tend to think that'd be quite that subacute generally. And then radiculopathies, or combinations of nerve root and peripheral nerves, and those include, of course, lumbar stenosis, slowly emerging lumbar stenosis with Cauda-Equina syndrome, neoplasms or paraneoplastic syndromes of nerve root, or possibly in combination with nerve infections like Lyme disease. Inflammatory causes, most notably neurosarcoidosis. Whenever I say inflammatory peripheral nerve or nerve root, or cord, I always think of sarcoid. Diabetic or idiopathic lumbosacral radiculoplexus neuropathy, although that's typically associated with pain. I mean, I don't know if you probably left some vital things out of the history, but it would typically present with pain. But that could present with weakness and numbness and gait disturbance. And then a number of peripheral neuropathies, most notably CIDP, or some of its variants. There's an asymmetric form of sensory motor CIDP called multifocal acquired demyelinating sensory motor neuropathy, or MADSAM. When Richard Lewis comes in March, we're going to stop calling it that for that day, and we'll call it Lewis-Sumner syndrome because it's named after him. So he's going to give us grand rounds in March and talk about probably that. And then the variant that is more distal acquired demyelinating symmetric variant of CIDP with or without monoclonal gammopathies. And most common subtype of that would be that with antibodies to myelin-associated glycoprotein. And then POEMS is one disorder that can present like DAD's neuropathy, but with other systemic complications, perineoplastic causes, neurolymphomatosis, pretty rare, vasculitic neuropathy. For more of this, the upper extremities, so I guess this is lower extremities, I probably should have left this out, neuralgic amyotrophy, which is brachial plexitis, heavy metal intoxications, all sorts of other intoxications, hydrocarbon intoxications, hexacarbons, toxins or medications like amiodarone toxicity, disulfiram. The list goes on and on. Nutritional causes, and I'm leaving out a whole bunch, but that's sort of a broad overview of the differential diagnosis. So, do you want to
That sounds good.
talk next?
All right. I'm going to go through a group of slides.
Just skip over my slides. I can always go back.
Okay. So we're going to get some more of that history, which we may have skipped over. And so talking more with him, he was generally a very healthy, highly independent man until just 6 months prior to this admission. He said it started with numbness and tingling in the bottoms of his feet. The symptoms gradually spread to his hands as well, and then progressed from the bottom of his feet up to the ankles, and from the fingertips up to the wrists. And then, in addition to numbness, he developed weakness afterwards, and this started with foot drop, first on the right side, and then progressing to the left side. Afterwards, he developed weakness in both of his hands to the point where he was unable to perform his basic activities of daily life, had trouble feeding himself, was relying a lot on his friends and family out where he lived in Idaho to help him with just his daily activities.
So Nick, what was the time difference between the foot drops?
Yeah, so the numbness and tingling started about 6 months prior to when he came in, spread to his hands about 2 months later, and then weakness was about a month after that. He started getting foot drop in one side, and I think there was about a month between the foot drop on one side and the foot drop on the other side. And then everything just worsened over about the next month and a half to when he finally ended up with us. He also said that he's developed shortness of breath. He feels like he's limited by that in his walking. He's only able to walk about 30 feet now, where he was a very active guy before, and at that point he feels like he's limited. In addition to his kind of leg complaints, he feels like he has trouble breathing. He spends most of his days in bed. Also, he has a poor appetite. He's cachectic and has lost 55 pounds in these last 6 months since it all started. The quote he gives us when he arrives, he feels very frustrated and just told us he thinks, I think I'm dying, I'm weak everywhere, and nobody knows what's happening. I'll give you a little bit more of the past medical history. Not much. GERD, erectile dysfunction, and he has idiopathic pulmonary fibrosis. He said this was diagnosed about 5 years ago in Idaho. He had a CAT scan that showed it, and he's never been on home O2 or required treatment. He feels like that's been stable. And then rheumatoid arthritis. He said that was diagnosed about 2 months before the rest of this stuff happened. He just woke up one day with pain in his joints diffusely, went into his PCP where ANA was negative, but his rheumatoid factor was positive at 105. He was treated with 1 month of prednisone, and he said those symptoms went away, and he didn't think much more about his joints after that. To round out the history, he's a retired veteran from the Navy, and then he was working in various print shops afterwards, doing labor-related tasks. He did have a 20-pack year smoking history, but quit 30 years ago. No other bad habits, rare alcohol, no illicit drugs, no significant family medical history, and he takes no medications. So I guess hearing what we know now, it would I'd like to hear how that might change your thought process and what you'd be interested in seeing on the physical exam.
Nick, can I ask one question
Yeah.
before we put Dr. Weiss on the spot again? He had a huge weight loss, 196 to 140. Did he feel that he was simply unable to get food to his mouth, or was this a weight loss?
So that was the big
despite,
question. He
being
was.
able to eat?
The question was, did the patient lose weight just because he physically couldn't get food to his mouth? And he did have a hard time feeding himself for about the last month before he came in, but the weight loss was really over, he feels like, the 6 months since the numbness and tingling started in his feet. He just had a hard time keeping weight on.
Did he have other autonomic features, orthostasis or GI symptoms?
He did not have any GI complaints, and he wasn't orthostatic. No lightheadedness came up in his questionnaire.
Is this rheumatoid?
Yeah, as far as he knows, it was just that one flare. That's when he was diagnosed, and he was treated for a month with prednisone, and it went away.
Oh, and no pain whatsoever.
He had pain in his joints with the arthritis, and after that was treated, he doesn't have pain now.
Dr. Weiss?
And I think most of us are thinking with the cachexia and the relatively subacute presentation that this could be something perineoplastic, and I think that would be a strong consideration. But I would have to say, based on the presentation of distal symptomatology, even without the exam, I'm now thinking that there's at least some component of this is a peripheral neuropathy. He's got distal sensory and motor symptomatology. Respiratory involvement, less clear as it relates to his pulmonary fibrosis. Does he have some other reason for that? Could he have a neoplasm that could speak to that? Could this be lung cancer, and then he has like a CRIMP5 antibody or some other perineoplastic autoantibody that can cause peripheral neuropathy? And other things, rheumatoid, there's a late sequelae of rheumatoid arthritis that can occur with vasculitic neuropathy. So I just saw a case recently, and sometimes the the arthritic component can be fairly stable before the vasculitic component involving peripheral nerve occurs. I think it's less likely. It's not, I'd have to say, given the lack of symmetry, it doesn't speak in the distal presentation, certainly doesn't speak to classic CIDP, probably not Dad's variant of CIDP. I guess I could speak still to Lewis Sumner's variant, or MADSAM, but I think that would be more likely to involve the arms, and most patients involve the arms first. I don't think that's as likely either. So the exam would help support the idea this is peripheral, looking for reduced reflexes. If it were a inflammatory demyelinating neuropathy, I'd expect the reflexes to be reduced fairly diffusely if it's more distal. It could be any of the things I mentioned that aren't inflammatory, that aren't CIDP or their variants.
All right. Thank you for helping guide us forward. So, on the physical exam, just in general, as you could guess, he appeared cachectic, normal vital signs, normal cranial nerves. He had reduced bulk throughout, no fasciculations on motor exam. And here is the result of his strength testing. As you can tell, he had 5 out of 5 strength in the deltoids, triceps, biceps. And then wrist extension and flexion was a little bit weak on the left, and then he definitely had weakness in the intrinsic hand muscles. And that was pretty symmetric, very distal on both sides. Same thing, the lower extremities, 5 out of 5 in hip flexion, and then 4+ in knee flexion extension, and then he really lost strength distally with ankle dorsally and plantar flexion, inversion, eversion. He could barely produce any movement. This was his little sensory map. He did have decreased sensation to all modalities, and it was in this stocking glove distribution. Really, the red is absent, light touch and pinprick. Distal and temperature distal to the wrists and the ankles, and then decreased distal to the elbows and the knees. His reflexes were 1+ throughout, but 0 at the Achilles and mute at the toes. His gait, as you could expect by his strength, he had bilateral foot drop and had a very hard time walking on his own, required a walker and at least one person to help him. So that brings us to our laboratory workup, and we can take questions from the audience, if anyone has ideas of what they'd like to check at this point.
Symptoms of bowel or bladder dysfunction.
Trying to remember, he had urinary retention when he came in. He'd had a Foley placed at the outside hospital. Someone had proposed this was from BPH.
Can I ask for 3 facts?
Yes.
The SPEP, looking for monoclonal gammopathy, herniaplastic panel, and did you guys do a VEGF level?
Okay, Dr. Weiss wants an SPEP, paraneoplastic panel, and a VEGF level. How about I'll hold that thought. Does anyone else have any first-line labs they'd like to check?
Can I have a set rate?
Sorry, what?
Sedimentation rate, a Western
Yes, sir.
sedimentation.
Okay.
I just had a question about the history. Do you know what kind of occupational hygiene measures were in place in the print shop that he worked in?
That's a great question about the possible exposures in the print shop where he worked. I don't know the details about the occupational hazards he was exposed to, but as far as testing him for heavy metals, we did go ahead and do that. Anything else?
A1C, B12, and maybe an ANCA.
Okay, yeah, so some first-line labs, A1C, B12, and an ANCA coming from Max, so A1C 5.2, SPEP was done in negative, UPEP negative, immunofixation also normal. B12 was 459 and his MMA was elevated. The caveat here is this was actually picked up by his PCP 2 months before he came to us. He was on B12 injections and that improved, but no change in symptoms. ANA was done and that was negative. That LFTs and that was normal aside from low albumin at 2.8. And then as far as not first-line labs, but some of the things that were mentioned in the audience, he had heavy metals, lead and copper levels, hepatitis serologies, HIV, Lyme disease, rickettsia. He had C and P ANCAs checked, paraneoplastic level, or paraneoplastic panel, that was negative. And then just kind of reaching some random things that have been done over TB, quantiferin, parvovirus. These were negative. Nobody checked a VEGF level.
Platelet count.
Platelet count. Oh, his platelets were normal. Yes.
Rheumatoid factor.
His rheumatoid factor was positive, as had been known before he came in, at 105.
Sedimentation rate.
It was normal.
It was normal.
Yeah, ESR and CRP were both normal. I didn't put it up here.
I was just going to make the comment this is a pretty broad workup, and it might have been more helpful to do the EMG first because it could have limited all this workup.
Thankfully, all of this had been done.
Right. Validating versus Axoma would have changed what you ordered.
Dr. Krauss is looking to save our tax dollars. Suggests that we could have done the EMG first.
And those of us who do, anybody get, when was the last time you did a heavy metal screening that came back? When somebody didn't have a high suspicion of heavy metal intoxication, got that.
I've never had a positive.
I don't think I've ever had
decades ago.
So there's an important test.
Okay. So I'm assuming that we would like to move on to the EMG. And could I have Dr. Weiss come up to take a look at the EMG and tell us what he thinks about these results. So we'll start with the motor nerve conduction studies.
And this was our study.
This was our VA.
So then what's really notable right off the bat is these are just of the upper extremities. The amplitudes, the compound muscle action potential amplitudes are abnormally reduced except for the ulnars that are low end and normal. So relatively normal on the right and quite reduced on the left. The latencies, vistomotor latencies are a little bit prolonged for the right median nerve or both median nerves and the left ulnar nerve, but given the degree of amplitude reduction, that can be explained by a dropout of faster conducting, largely or more thickly myelinated nerve axons, and that make up the initial part of the waveform, and that will delay the responses and can also cause some slight reductions of conduction velocity. This velocity is reduced, but probably none of this is in the range of a primary demyelinating neuropathy. I guess this one could argue, but the amplitude is so tiny that sometimes the onset is hard to find, and then this velocity is probably may not be accurate because it's hard to know exactly where to put the onset markers. So this looks primarily like an axonal neuropathy. It's very different from side to side, so I would call this a motor mononeuropathy multiplex. Should I go through another one?
for it.
Okay, so then there's the lower extremities. So the lower extremities, easy to go over and quickly because there are no responses for both peroneal nerves and the right tibial nerve recording in the foot, and then recording over the right tibialis anterior muscle for the peroneal, there's no response. The left one, there's a tiny, tiny response. Velocity across the knee is normal. So again, it looks like a axonal neuropathy, and it's, here's the left tibial, there's also no response. So it's pretty severe. So far, we just know about, is it sensory next?
Sensory.
Okay. So far, we just know about motor nerve conduction. So let's see what, so sensory, this is an easy one. There are no sensory responses. So pretty darn severe. Is there more? EMG? No needle EMG?
Oh, yeah,
Okay.
needle's next there.
Okay, so needle EMG. So needle EMG, we're looking for evidence of ongoing denervation or active denervation in the form of spontaneous activity, fibrillation, potentials positive. Sharp waves are kind of lumped together here. And there is some denervation in the first dorsal neurosseous, abductor pollicis brevis, and then the distal lower extremity, so it's length dependent here. And then the motor unit morphology is what's the acuity is only six months. Motor unit morphology is actually surprisingly normal, which I find a little bit hard to believe actually, but recruitment is quite reduced for a couple of the muscles. Okay, is that it?
No, that's, yeah.
Okay. So do you want me to say where I'm?
Yeah.
Okay. So this looks like a an axonal sensory motor mononeuropathy. Multiplex is quite severe to the point where you have overlapping mononeuropathies. So it looks more like a symmetric polyneuropathy. And so this looks like I favor some form of vasculitic neuropathy. Am I supposed to say that? No.
Say whatever you're doing. Thank you very much.
Any labs that you want?
Yeah. Given what you found.
Labs. We already talked about rheumatoid factor. ANA multiplex panel. Did you order that one?
Okay.
Did you show that one yet?
No, not yet.
Okay.
Okay. So, well, we'll come back to some of the labs. I want to delve into a couple other things that did bother us about his presentation. He did persist on feeling short of breath, out of proportion to everything else going on. We got a chest X-ray when he arrived, and this is what it showed. So I just wanted to bring this one up. It shows a coarse interstitial lung markings here, and there's honeycombing that's consistent with his known pulmonary fibrosis. Because of the cachexia, and even though the paraneoplastic panel was negative, he did end up getting a CT chest, abdomen, pelvis with all this weight loss, and he had a prior CT to compare it to as well. So this is the CT of his chest, and I just wanted to point out the pleural honeycombing here. It's quite dramatic on both sides. This was actually increased from his prior CT in 2014 markedly. Just to add on pulmonary function tests, because he had those before, we repeated them. His FE1 to FVC ratio was maintained, although both were reduced, consistent with the restrictive defect, which we knew about. His DLCO, diffusing capacity of carbon monoxide, was severely reduced and worse from 46 to 24% compared to when he'd been tested about 2 years prior.
So the test is MIP?
I don't recall what the MIP was. The question is, the test is MIP. I can't recall. It was probably low. Okay, and then before we get back to some more specialized labs, I want to throw up the labs on admission that I sort of intentionally did not point out earlier. So here's his metabolic panel and his CBC. The one thing that stands out here is his creatinine of 2.9. When he arrived in transfer, he had a Foley in place. We were told he'd been obstructing. He had over 1 liter of retention, and this was thought to be an obstructive process, an acute kidney injury. And so we planned to take his Foley out and give him a trial, but as he was in the hospital, that creatinine didn't come down. We started looking back at where he'd been prior. When he had initially seen his PCP, he indeed had normal labs 1.16 months ago. But on follow-up visits and hospitalization after that, he had this pretty consistent trend up from 1.1 to where he was on admit at 2.9. So that prompted us to do a little bit more in the way of renal investigation, sending a urinalysis. Non-infectious, no leukocytes, no white cells, but he did have a little bit of hematuria, 48 red blood cells seen in his urinalysis. He did have microscopic hematuria, and he had trace protein. If you recall, the one abnormal thing on his LFTs was a low albumin. He also had a low prealbumin, and so appeared to have proteinuria and hematuria here. The renal fellow looked at his urine and thought there were some granular casts. His microalbumin in the urine was high, and the fractional excretion of sodium was in this intermediate range, not really consistent with an post-obstructive process. Renal ultrasound, not that helpful, but did show increased echogenicity consistent with medical renal disease. So this is where we did decide to do a more extensive autoimmune lab workup, as Dr. Weiss was asking for. We had previously checked C-ANCA and P-ANCA. We added the anti-PR3, and that was negative. And then the anti-myeloperoxidase came back positive at 93.6, whereas it is normally 0 to 9. So it was quite elevated. So at that point, we did have renal on board, and the next step was a kidney biopsy. We have Dr. Roberto Nicosia here visiting us from the Seattle VA. He's a professor of pathology here at the UW, and he's been the director of pathology and laboratory medicine at the VA for many years. Just recently sort of retiring from that position to focus on his research. And he's here. We're very glad to have him to review the pathology with us.
Well, thank you, and thank you for inviting me and giving the opportunity to present this very interesting case. When we received the biopsy, the clinical differential diagnosis included glomerulonephritis, tubulointerstitial nephritis, vasculitis, basically the whole spectrum of possible causes of acute kidney injury. This is a low-power view of the biopsy, and just briefly to let you know that we use a special stain. We use a number of stains in renal pathology. One is a silver stain that allows us to highlight the basement membranes of tubules and glomeruli in black against the background of hematoxylin and eosin stain. Low power view right now is somewhat difficult to see the details, but normally low power, the kidney should look like this, so with tubules back to back and very inconspicuous interstitium. Instead, as you can see in this additional image, the tubules are separated by an intense inflammatory reaction, which is widening the interstitium, and the glomeruli are hardly visible at this magnification. This is one of the normal glomeruli. Up to 1/3 of the glomeruli in this biopsy look normal, and you can see the you can see the capillary loops, open capillary lumina in urinary space. The mesangium is very inconspicuous. The Bowman's capsule, which is the circle around the glomerular tuft, is stained in black. But basically, this is a normal-looking glomerulus. Up to 1/3 of the glomeruli look like this. But up to 60% of the glomeruli instead had this morphology. The glomerular tuft was compressed, pushed to the side by a proliferative process that was engulfing the urinary space. It's what we call a crescent. And within that crescent, there is some pink material that you can see that is fibrin. So this is a crescentic, necrotizing and crescentic glomerulonephritis responsible for the renal failure. Interestingly, well, first of all, let me let me show a higher magnification, the view of one of these glomeruli. You can see this pink material, this fibrin, that has accumulated in the urinary space as a result of a necrotizing process of the glomerular capillary tufts. And there is extensive proliferation of epithelial cells within the urinary space, which is essentially totally obliterated by the crescent. And this is a fresh, recently formed crescent. This slide summarizes the spectrum of pathologies we were able to demonstrate in this biopsy, from normal glomeruli to glomeruli with very active crescents and glomeruli that had crescents that were undergoing a process of fibrous organization, and finally glomeruli here in the lower right panel, which had been completely destroyed by the crescent, so they were hardly recognizable. And the remnant of the glomerulus was surrounded by a granulomatous reaction with very intense inflammation. An additionally interesting finding in the biopsy is shown here in the lower left part of the image. It's an interlobular artery, better shown at this high magnification, exhibiting a necrotizing fibrinoid process. This is what we call fibrinoid necrosis. The lumen of the artery is barely noticeable where the arrow is, and the wall is very thick and transmural inflamed, and the pink material that you see beneath the endothelium is fibrin. So this is a necrotizing arteritis involving a small artery, an interlobular artery in the kidney of this patient. In addition, the interstitium was heavily inflamed, infiltrated by mostly mononuclear leukocytic cells that were also engulfing the tubules, and there is evidence of active tubulitis. So basically, we have a necrotizing and crescentic glomerulonephritis associated with a necrotizing arteritis and active tubular interstitial nephritis. The differential diagnosis of crescentic glomerulonephritis includes immune complex-mediated glomerulonephritis, anti-glomerular basement membrane disease, and post-immune glomerulonephritis, which is ANCA, typically ANCA-associated. Now, given the serologies in this patient, we felt that this is consistent with a post-immune type glomerulonephritis, also because our immunofluorescence studies and electron microscopy as well show no evidence of immune complex deposition. The only findings by immunofluorescence of significance were shown here. We were able to demonstrate abundant deposition of fibrin in the crescent, as already suspected based on the line microscopy. Here again is a high magnification view of a glomerulus stained with an antibody against fibrin fibrinogen that is highlighting the morphology of the crescent that is fibrin-rich. So these are final diagnoses: necrotizing and crescentic glomerulonephritis, post-immune type, necrotizing arteritis, which is related to the glomerulonephritis, and acute tubular interstitial nephritis with associated acute tubular injury and tubular dropout, likely related to the glomerulonephritis. We also found that a few glomeruli were sclerosed. Most likely this was the result of the glomerulonephritis that had occurred a few months prior to the patient presentation, and was showing basically a spectrum of changes from very acute lesions to chronic lesions, including the glomerulosclerosis.
So I've been tasked to tell you guys about the final diagnosis, which was microscopic polyangiitis for him. And that actually turned out to be difficult because there's not a lot of studies that look just at microscopic polyangiitis. It's usually been studied with its cousin, which used to be known as Wegener's, but is now known as granulomatosis with polyangiitis. So the definition of microscopic polyangiitis is a necrotizing vasculitis with few to no immune deposits, predominantly affecting small vessels such as capillaries, venules, and arterioles, as we saw in the biopsy. And that was a definition set forth by the Chapel Hill Consensus in 2012. And the Chapel Hill Consensus actually didn't give any criteria for diagnosis, which is unfortunate because the American College of Rheumatology also doesn't have a strong criteria for diagnosis of microscopic polyangiitis. It's diagnosed by excluding granulomatosis, which is a feature of Church-Strauss syndrome, and granulomatosis with polyangiitis, or Wegener's. And those are the three small vessel diseases or small vessel vasculitis that you will see most commonly. Clinically, the features overlap heavily with the other small vessel vasculitides, but diagnosing them and differentiating between them is important because there are different outcomes. In particular, GPA is associated with a higher rate of relapse than microscopic polyangiitis. So a word on ANCAs. So ANCA and autoantibodies can be positive in all of those small vessel vasculitides. 70 to 75% of patients with MPA are ANCA positive, and in patients who are ANCA positive, the P-ANCA is more likely to be positive than the C-ANCA. About 87% of the patients are P-ANCA positive as compared to C-ANCA in only about 13%. The P and C-ANCAs refer to immunofluorescent staining patterns, whereas the actual antibodies that we checked in this patient were positive, and that was the anti-MPO antibody, which was positive. In MPA, the anti-MPO antibody is positive more frequently than the other antibody that's also associated with the ANCA patterns, which is anti-PR3. Granulomatosis with polyangiitis is more heavily associated with the anti-PR3 antibody. So the incidence of MPA is about 3.6 cases per million in the United States. It's much more common in patients of European descent or Asian populations, as many as 2 to 4 to 1 in some studies. Interestingly, GPA is much more common than MPA in the European population, but that pattern is reversed in Asian populations where MPA is much more common. Men are slightly affected more than women, and the average age of onset is in the 50s, but it can be seen in a wide range of age groups, anywhere from the teenage years all the way up to the 80s. Without any treatment, the mortality for a small vessel necrotizing vasculitis, including all of them, not just MPA, is about 80%, but with the advent of treatment with glucocorticoids and other immunosuppressive therapy, that has improved drastically. The presentation is fairly nonspecific. The most common presentation that comes to clinical attention is constitutional symptoms such as malaise, fatigue, weight loss, as we saw in our patient, arthralgias, myalgias, those sorts of things. And then the next most common is renal failure. Ear, nose, and throat lesions are also fairly common in MPA. Although it's classically associated with Wegener's and Sjögren-Strauss, MPA also has this as well. And you might see a range of anything from nasal discharge to uveitis to conjunctivitis. Sometimes cutaneous disease is present as well. And then there's a wide range of pulmonary symptoms. Wegener's has much more been associated with pulmonary symptoms than MPA. In Sjögren-Strauss, as we know, there's eosinophilia and asthma, but MPA can have this feature as well. And in our patient, we saw the honeycombing that was present on the CT, which may be associated with his vasculitis. And then neuropathy is rarely a presenting symptom that brings a patient to clinical attention, but it is present in many cases, up to 70% in patients with MPA versus only 15% in patients with GPA. So the diagnosis focuses on excluding any alternative diagnosis. That says CNC, but that should be a CBC, and as well as the basic lab work, checking the renal function, ESR and CRP, ANA, any of the other things that could potentially cause a vasculitis, like checking complements, cryoglobulins, hepatitis serologies. A urinalysis is important for looking for proteinuria, which was present in our patient, as well as hematuria, and then chest imaging for any patients with pulmonary symptoms. Any patient who's suspected of having vasculitis should get ANCA testing, but 10% may be ANCA negative, and if ANCA is negative, or even if ANCA is positive, then you would also want to check the anti-PR3 or anti-MPO, because this may lead you down a different diagnostic track. And then if there are any active lesions, they should be biopsied, which will really give you the only definitive way of making a diagnosis to look for the actual vasculitis with or without granulomas. And even if biopsy is not possible, you shouldn't hesitate to start empiric therapy.
Can I ask a question about the lab tests that you throw up there? Is it typical to have a normal ESR with MPR?
No, usually it would be elevated in most of the vasculitis.
So that's an oddity of this particular.
Yeah.
Does this patient didn't mention his percentage of eosinophils? But I guess Nick didn't mention that.
Yeah, that's a good point. I don't actually remember if they were elevated or not.
I was waiting to see that. Okay. It was not a prominent feature in the biopsy.
It was not. I was going to ask you if you saw
Usually in Sjögren-Strauss we get a lot of eosinophils.
I don't remember it being a feature, but I don't exactly remember. Another question?
Usually I think of pain with vasculitis.
Yeah, I was gonna
Vasculitis not the pain.
So yeah, it can be painful. Any of the lesions that were mentioned can be painful, and then the neuropathy is painful as well.
It usually is, Patricia. That I agree. That was surprising. You didn't have any pain.
Is there PR3? What would that go to?
The anti-PR3 is an autoantibody that I think usually stains cytoplasmic, or the C ANCA. Yeah. Yes, Dr. Krause.
What's anti-MPO?
Sorry?
Anti-MPO? What's
Anti-myeloperoxidase. Yes, Dr. Krause.
Certainly a good learning case that the ANCA can be negative, but these other antibodies can be positive. I was just wondering, because of this, do they automatically do a reflex panel and look for PR3 and MPO when you order an ANCA, or do you have to order those specifically?
I don't know in all cases. I know in this case we had to order them specifically. Does anyone else know at other hospitals? Do you have to order them separately?
Separate,
Yeah.
And you know, I even hematology sometimes I follow patients with ANCA negative Wegener's. I never quite know. There's a few different reasons I know hematologists like that. Not that they would have these things, but ANCA doesn't say it all, I guess.
Right. Yeah, and I think that's one of the features of these vasculitides is that it's very hard to make the diagnosis because the ANCA is neither specific nor sensitive. The antibodies as well. You can have patients that are double antibody positive.
So I gather you didn't biopsy a nerve.
No, we did not biopsy.
We went after the kidney. Is that normal?
Is that
Mhm.
sort of the nerve?
Would you have gone after the nerve?
No, I think you're probably right to go after the kidneys. Because the nerves, you couldn't get any response. When would you have biopsy? You could change it to end-stage neuropathy, and you wouldn't have gotten any active disease.
It was surprisingly easy to get a kidney biopsy. It would have been taken after Congress to get a nerve biopsy. But they just did it at bedside.
Wow.
Yeah, it just took a couple days. It's not all bad. All right. So because we're neurologists, I'm going to talk about neuropathy. 70% of patients with this particular syndrome, the MPA syndrome, have neuropathy at some point during their disease, and there's a chronic neuropathy that continues in 15%. The mechanism of injury can be ischemia in that there's thrombosis of these very small vessels that are usually not present on any imaging, but they have microinfarcts that then lead to injury of the nerve, and then also with the inflammation process, there's release of free radicals and nerve damage. The pattern is asymmetric. It can be patchy originally and then may become symmetric later in the disease course. Distal extremities are affected slightly more than proximal, and motor more than sensory, according to some limited studies, but usually what you see is a sensory motor pattern with both involved, and it turns up as an axonal pattern on EMG. Common presentations include mononeuritis multiplex, which is the most specific nerve injury pattern for vasculitis, and then a distal symmetric polyneuropathy. So treatment for mild disease can be glucocorticoids alone, and if you have a patient that just has neuropathy and then no other systemic symptoms, that would count as mild disease and could be treated with glucocorticoids alone for a month. However, the nerve injury can cause a high degree of morbidity, so it would be reasonable to pursue more aggressive treatment as well. Treatment for moderate to severe disease, which is any disease with active glomeruloneuritis or other organ-threatening or life-threatening complications, and that's the category that our patient fit into, would be pulse dose steroids for 3 to 5 days, and then daily prednisone of 1 milligram per kilogram for several weeks to months. And that would be accompanied by a rituximab or cyclophosphamide infusion. Most studies have been done with cyclophosphamide, but rituximab has demonstrated non-inferiority and might be preferred for someone who doesn't want the side effects of cyclophosphamide. Plasma exchange has been tried, but there's no benefit currently with moderate to severe disease in most places, but there are ongoing investigations that are looking at patients with severe or rapidly progressive renal dysfunction to see if plasma exchange might be of benefit in them. The goal of treatment is remission, which would be defined as the stabilization or reduction in the serum creatinine or any other extrarenal manifestations. And this is monitored by inflammatory markers, which wouldn't be very valuable in our gentleman since none of his were elevated, kidney function testing, which would be of value, and then any clinical symptoms. In looking at GPA alone, there has not been any value established for following autoantibody titers, but that may not hold true for MPA. We just don't know because there haven't been a lot of studies on MPA alone, but following the disease progression with autoantibody titers has not been shown to predict relapse, so is not really valuable. About 85 to 90% of patients for both GPA and MPA can sustain remission with glucocorticoids and cyclophosphamide. The complete remission is seen in 75%. There is a higher relapse rate in GPA more than MPA, and our patient was anti-MPO positive, which confers a more positive prognosis with a lower relapse rate, which is good for him. Remission was usually achieved in 2 to 6 months, and then after remission, maintenance therapy with azathioprine, methotrexate, or rituximab is continued for 12 to 24 months. In patients who have good prognostic features, such as the presence of the anti-MPO antibody, or a disease more on the MPA spectrum than GPA, could have therapy that only lasts for 6 to 9 months and then discontinued. The neurologic symptoms usually stabilize within 2 to 6 months, and there's a low relapse rate, but the neurologic symptoms can still have a significant impact on functional outcomes, and many patients continue to have a great deal of morbidity from them. So in our patient, we treated him with 3 days of methylprednisolone for 1,000 milligrams a day at pulse dose. He got weekly rituximab infusions for 4 weeks, and then he was treated with high-dose oral prednisone following the pulse dose steroids for about 2 months. Prednisone was stopped by June, which was 4 months of his initial presentation to us, and then he's now doing the maintenance phase with single-dose rituximab infusions, 1,000 milligrams every 4 months, and that is going to be continued for 2 years. He moved back to Idaho, so we're following him remotely. He still has anti-MPO elevation. As I said, there's not a lot of utility in checking it, so I'm not sure why, but it is interesting to note that his anti-MPO is still elevated. It's around 25, and he is pretty functionally improved. He had a stay in rehab that lasted a couple of weeks and then moved home. He's currently ambulatory, and he can do things like button his shirt, hold his utensils, feed himself, which he couldn't do before coming to the hospital. He is driving, although this is a point of contention with his physicians, but he is driving using his braces on his feet to push down on the pedals.
His titer was 900.
It was 90.
All right.
His creatinine is around 2.25, so it hasn't completely resolved and gone back to baseline, but it's stabilized and hasn't gotten any worse.
I guess you wouldn't necessarily expect the kidney to get better if he's destroyed a bunch of those glomeruli. The most you can hope for is that it's stabilized.
Yes, I think it will be difficult for the kidney function to go back to normal, given what we saw. Because some of the glomeruli were already obsolescent, completely destroyed. Others were in the process of being destroyed. And many glomeruli, quite a few glomeruli had a destroyed Bowman's capsule. Once the Bowman's capsule is destroyed, the possibility for the glomeruli to recover is essentially
That's what I was
zero.
What about his weight?
He has gained weight. I don't know exactly how much, but the last note I read for him said he gained around 8 pounds in a month. So.
Dr. White,
Good news,
is
hopefully.
there utility in repeating EMG to look for spontaneous activity as an indication for disease activity?
Well, he had spontaneous, any more spontaneous activity? He had spontaneous
If he has no
activity.
spontaneous activity now, would that be an indication that disease is biased?
I don't think so. I think all you could hope for is some, I mean, it's surprising he has much functional recovery that quickly, given he has virtually no responses on nerve conduction, either motor or sensory. I think that you would gain more insight from looking at nerve conduction as he have responses that were no longer there to suggest that he's recovering. I don't think needling is going to help you very much.
Would you have treated him differently using cyclophosphamide or
I'd have to use a cyclophosphamide only because if he had private insurance, it probably improved rituximab. So I've been, of course, Greg Gardner and I work together in the neurology rheumatology clinic, and this has come up a lot. We don't see this,
But we've seen a few cases of Church-Strauss. We've seen patients with hepatitis C with cryoglobulinic vasculitis. And for those patients who either are ineligible for the antiviral therapy or don't respond, rituximab is a treatment of choice. There was a huge randomized controlled trial that was published in the rheumatology literature, in a journal. They actually had to stop the study in midway because patients were doing significantly better with interim analysis with rituximab. Can't get insurance companies to pay for it. Now, VA, different story.
Surprisingly,
I was amazed that you guys have
the VA, it's
rituximab.
pretty easy to get rituximab.
I'm going to have to, if I have any patients that I'm trying to do it for, I'm going to make sure they're not a veteran then and send them your way if they are.
So he was completely numb. You showed us the yellow and the red distribution of his sensory findings. Did he recover feeling in his distal extremities?
I don't know about that. He went back to Idaho, so most of the information that I have on him is just looking at charts, and I don't think he's seen a neurologist recently to document a really good exam. But yeah, I'm not sure about that. He does have some motor function, apparently.
Yeah, he couldn't open like crackers, he couldn't feed himself before, so that's why.
See if we have any questions.
So I had a question for the neuromuscular specialist in the room, and I don't know if I have the timeline perfect, but you showed that graph of his worsened kidney function, and it sounded like he was already quite symptomatic with the foot drop and these other neuromuscular symptoms at that point. Had you gotten that EMG that suggested a myeloneuritis multiplex that could be due to a vasculitis, but his creatinine was kind of not that exciting, you didn't get the biopsy, how aggressively would your empiric therapy would have been at that point? Not knowing from the biopsy that this was a microscopic polyangiitis.
You mean if he didn't have any other systemic manifestations
Right,
at all?
and just these symptoms and that EMG.
So non-systemic. He had no systemic symptoms, but apparent myeloneuritis multiplex based on EMG. I might have done a nerve muscle. I would have done a nerve muscle biopsy. I would have gone after nerve muscle. So if he didn't have any, so usually I treat empirically in patients who have some reason to treat based on serologic testing or really clearly established risk factor, or if they have some other systemic disease. I'm sorry. So I would treat empirically without doing a nerve muscle biopsy if patients had some other reason to treat them. They had known terrible rheumatoid arthritis or hepatitis C with cryoglobulins. I don't typically do a nerve biopsy then because I'm in with Greg Gardner, who I've been working with pretty closely in the neurology rheumatology clinic. But if they have no serologic markers, they have no systemic disease, I would try to do a biopsy just to try to prove that that's what they have, even with a nerve conduction study showing a myeloneuritis multiplex. Problem there is that you can sometimes get skip lesions, but I still would probably do a biopsy before treating a patient who has actually no immunologic factors, no other reason to have vascular neuropathy, just to hedge my bets. And I would do not only nerve but muscle, underlying muscle, because that increases the likelihood you're going to see signs of vasculitis. So the question is whether to go after superficial peroneal sensory nerve. And that seems to be the favored nerve if we can get the surgeons to do it in the underlying peroneus brevis muscle. If I can't do that one, I would probably do sural nerve gastrocnemius. And we can sometimes talk the surgeons into doing superficial radial and forearm extensor muscle. Somebody has some arm predominant symptoms. They don't like to do it, but they will. Hands or plastic, they might do it.
All right, thank you, Dr. Weiss and Dr. Nicosia, for taking part in our CPC. If there are no other questions.
The certificates.
Thank you, Dr. Freeburg, Dr. Roberto.